Welcome to Hacking Hypermobility Podcast.
I'm Luna.
And I'm Shelly.
And we're two bendy mamas.
Hacking Hypermobility. Hey, welcome back, everybody, to the podcast. Thank you for joining us today. I'm confused. No, I'm not confused. I'm going to keep talking. I scrolled on the computer to a different page, and the page is in front of me. So we're just going to start over. No, we're not. I'm just going to keep talking. So welcome back, and thank you for joining us today. And as we've started talking about this journey into your medical evaluation for hypermobility disorders, including the Ehlers-Danlos syndromes and hypermobility spectrum disorders, EDS or HSD. So
if you didn't catch our last episode about the barriers to our care, we recommend you go back to episode 3 to get some helpful advice to help you prepare.
Yeah.
In this episode, we're going to go ahead and start talking about the presently used scoring tool for the initial portion of the evaluation of hypermobility. We're going to break down the first box labeled Criterion 1 on the HEADS diagnostic criteria. So just to be clear, though, the diagnostic pathway according to which type of connective tissue is suspected differs, and you could go down a different path depending on your particular presentation of your hypermobility. So HEADS, HSD, those are more common. The diagnostic pathway differs from that of the more rare types of connective tissue disorders and the more rare types of EDS. Diagnosis largely has its basis in the identification of a collection of symptoms, though.
Symptoms, right. And so symptomatic hypermobility can be due to many things, including specific heritable disorders of connective tissue like Ehlers-Danlos syndromes, Marfan syndrome, which we've talked about briefly, Stickler syndrome, which I think we're going to talk about later, osteogenesis imperfecta, and others, as well as joint shape, having looser ligaments or poor muscle tone, and that can be with or without a connective tissue disorder. There's also other conditions like Down syndrome, cerebral palsy. Please apologize. I am struggling with some weird GI issues as far as like talking and throat stuff. So my voice might get I might have a little vocal fry, and also like I've been slurring and I'm not trying to. So if that comes up during this episode,
it's okay.
Just be aware of that. I have a barium swallowing test tomorrow.
So we're overthinking all of this stuff.
Yes, like I'm hyper focused on how well I'm speaking, and I'm not doing it very well. So anyway,
not very podcasty of us.
I'm not very podcasty today, but we need to get this episode out. So anyway, the other thing that can be symptomatic of hypermobility is if you have an injury or repeated stretching. And so yoga enthusiasts and gymnasts, things like that. And also what now?
And now even COVID-19, long COVID, is associated with hypermobility syndromes and some of the comorbidities, including POTS.
Yeah.
And mast cell now.
Oh, no, I didn't hear the mast cell part.
Yep.
Great.
So, long COVID friends, welcome. Now, for transparency, though, we are not medical providers. We're speaking from the experience both as patients. Also, there are other inherited connective tissue disorders. That's not a fully extensive list. So be persistent in working with an informed medical doctor on your own zebra journey, which is particular to the inherited, Ehlers-Danlos syndromes. But be mindful, there are other causes of these symptoms and hypermobility. And that is why it's so vital to work with a doctor to find a provider aware of the various presentations of the hypermobility disorders if it's affecting your health and you have multiple systemic issues.
All right. So, Luna, can you review our Hacking Hypermobility general steps to getting a diagnosis for everybody?
Yeah. So our big hack from the last episodes were, first, you need to document and organize your symptoms and history. Gather it all up together, get yourself organized. Number 2, find a provider. 3, get screened for hypermobility. 4, the clinical evaluation of generalized joint hypermobility. 5, the clinical evaluation of the criteria for hypermobile Ehlers-Danlos syndromes, which includes scoring of your hypermobility and an evaluation of the additional features in your history, as well as the exclusion of other diagnoses, because HEDS is a diagnosis of exclusion currently. And then finally, if warranted, genetic testing and consultation.
Okay. And so first you should be evaluated to determine the severity of your hypermobility. And so based on your clinical presentation and the history, which Luna just mentioned that you're going to document, your doctor will decide how to proceed. So how do you get evaluated?
So, once you've come to the conclusion that you may have some more issues going on and you want to approach this with your doctor, you bring up your concerns related to hypermobility and any other health issues. The first medical assessment will involve an assessment of hypermobility. Hopefully, your primary care provider is willing to do this initial evaluation with you. If not, depending on the specialist availability in your area, you may complete this evaluation with a type of specialist called either a rheumatologist or even a geneticist. I've even seen an orthopedist do this evaluation. However, most are surgically oriented, and also even other types of practitioners might do this and then refer you on. Some chiropractors have done the evaluation. Some physical medicine doctors have done the evaluation and refer patients on to. So it just kind of depends on what your own personal journey is and what health issues you've been dealing with or seeking help with and what providers you've seen.
Yeah. And so we recommend that you familiarize yourself with what to expect, which is what we're doing right now. And so presently, the published HEDS criteria for diagnosis uses something called the Beighton score. And that's like the first step. And so that criteria are published on the EDS Society website, and we will link it in the show notes. And it was also part of your homework. Did you do your homework? Yeah. I actually forgot we assigned homework because I
think it was kind of a joke.
But I know. But
kind of a serious joke. When we said, hey, get yourself organized, we said, hey, go look at this criteria. So if you did that, if you've got the HEDS criteria in front of you, this is the first box at the top of the page. It's labeled Criterion 1. It is for the evaluation of what they call generalized joint hypermobility. It's really just the assessment of, are you experiencing hypermobile joints? So this section of the evaluation begins with the measurement of the flexibility of just 9 joints that are scored. And then there are some additional screening questions about your history. So this 9-point scoring system is called the Beighton score. And it has different thresholds for 3 life stages that align with the progression of hypermobility disorders such as EDS. Since hypermobility disorders change over the course of a lifetime, these scores change as you age. HEDS patients typically show increasing symptoms as we approach adolescence, and then as our bodies experience wear and tear over a lifetime, change presentation again as we age. So the 3 life stages defined with decreasing thresholds for this score are first the prepubescent one. So before you go through puberty, the hormonal changes that bring on adolescence. The second stage is post-pubescent, so that's typically teenagers and then adulthood. And then finally, the third stage, the third scoring threshold, which is the lowest, is for people over the age of 50.
All right. Okay. So we're talking about the scoring system. How did they come up with the name Beighton, or is it Beighton? I always said Beighton. Am I saying it right?
So I actually looked this up because of
course you did.
Yes.
That's why I didn't, because I knew you would.
So according to a tweet from Dr. Emma Reinhold, who is a UK general practitioner that spearheaded the previously referenced GP Toolkit project in the UK, who also her Twitter is fantastic. According to Professor Rodney Graham, the godfather of hypermobility, who knew people, yes, people, more than one person, the Beightons, it's Beighton, like take a bite out of crack. It rhymes with Brighton, as in the old criteria for joint hypermobility syndrome.
So that's where it came from too, because I was like, the name, did they just like tweak the
name? Make it confusing? Like, why is it like this? Yeah.
Yeah. So it's actually, it's a people, and it's not like we're just going to be deliberately confused.
It is a person and their spouse. So it's funny though, they made the joke that having the scoring criteria one letter apart was the biggest mistake of their career. So the old criteria, the Beighton criteria, is no longer used, but the Beighton score is still used.
So it's Beighton criteria, Beighton score.
Yeah. And so the Beighton score is someone's name. So it was born out of early research dating back to actually 1964 when modern hypermobility research started happening. So the Beighton score has its origins when Cedric Carter and John Wilkinson devised a scoring system investigating congenital hip dislocation in Great Britain.
Oh.
And that method was later expanded by a researcher named Peter Beighton.
Okay.
And a nursing sister named Greta Winch studying EDS in London in 1971. Together, the pair actually married, so they are the Beightons.
Okay.
And they studied the epidemiology of generalized joint hypermobility in the Kalahari semi-nomadic Bushmen and the Tswana population in South Africa.
Okay.
So Greta actually noticed that hypermobility could be different depending on right side, left side, expanded the score that was previously used, expanded it to the 9 points that we use today. And the story is she actually came up with this like around a campfire. When I tell you like they were doing research in the field with the Bushmen, yes, this criteria was like expanded around a campfire in South Africa. So the study results were then published in 1973. But by the way, fearing accusations of nepotism since they were a married couple, she was not credited as an author in that 1971 study. She has been recognized posthumously, however, though, which is nice. I appreciate that, especially as a woman in STEM. So it's important to note that the origin of the scoring system that we still use today was to identify hypermobility by scientists studying another culture than their own in a non-invasive way with some distinct language and cultural barriers and differences. So it was an epidemiological tool in the study of the epidemiology of bone and joint disorders. It's quite different from what we are talking about in terms of clinical application and assessing patients and diagnostic criteria. So now you might be wondering, okay, well, what's epidemiology? Well, I kind of just gave you, a description. So they're in the field, they're studying a different culture. That's not necessarily a requirement for study of epidemiology, but it's a branch of medicine that deals with the incidence, so how frequently something occurs, the distribution, how widely it occurs, and possible control of diseases and other factors relating to health. So it's a research-based health study practice, just trying to understand where a disorder, a disease comes from. Okay, so this epidemiological or research tool was later adopted to clinical practice.
Okay.
And by clinical practice, I mean how we manage patients, like to help manage their disorders, diseases. When you go to the doctor, that's what I mean by clinical practice. And so as a result, the Beighton score is a basic screening tool that identifies some visible and easily identified hypermobile joints, but not everything, right? In 2017, the International Ehlers-Danlos Syndrome Consortium published revised diagnostic criteria, and the name was modified slightly to this new diagnostic term we know as HEADS, which stands for Hypermobile Ehlers-Danlos Syndrome.
That's when they changed it from like EDS type 3, right?
Right.
2017.
That is the current terminology and the current criteria, the 2017 criteria. When I told you to do your homework and go to that worksheet, this is what we're referencing. So the first portion of that HEADS diagnostic checklist begins with identifying generalized joint hypermobility using this scoring method from the Beighton's research, from the South African Bushmen around a campfire, trying to find a way to identify hypermobility in these tribes people that they had difficulties communicating with. So for the purposes of their work, though, the scale was well suited, being easy and quick to perform in large numbers of people. It was almost like conversational. We can, assess these things without really, going into a physical exam room or anything. So it's not a full body assessment though, and it does not account for the varied presentations of inherited connective tissue disorders that present with hypermobility. It has its limitations. That is why the first section of the HEADS criteria, there are some additional clarifying questions. So let's break down first this 9-point system known as the Beighton score and those clarifying questions.
Okay, so we're going to describe the scoring system, but we recommend a video to see the assessment, and we're going to put that in the show notes. And just so you know, a joint is where two or more bones meet in your body to allow movement. I know what you were thinking because I was mentioning joint. Okay, no, I'm talking about the ones in your body. There is a typical range of movement, and that flexibility is measured with an instrument called I should have looked this up, a goniometer? How do you say that, Luna? Goniometer? I didn't pre-practice that.
I've heard it called
goniometer?
Joniometer?
Joniometer.
I don't know.
So it's like the J, not the G. Okay, it's Goniometer.
Goniometer.
My guess is, though, you're not going to have one of those. Don't go buy one.
Don't. No. If you're going to buy anything, buy one of these. Okay. I recommend. We'll put that in the show notes too. Anyway, enough about that. Can anybody just do this? Can I just be like, hey, let me watch this video and you're going to assess me? What do you think?
Yeah. So no. I do recommend you watch the video to understand what we're looking at, and then you kind of get an idea of the checklist and what they will measure. But it's important that someone medically trained on measuring range of movement performs these measurements. So there are anatomical landmarks and medical techniques in positioning your body as you are measured to ensure accurate assessment. But in some of us, the flexibility is so pronounced.
Yeah.
You can see it even visually with an untrained eye. Still, we want you to be
like this.
Yeah.
See people? Yeah.
So she's showing you her backward elbows. And it's funny to me because I was literally
one is worse than the other.
Yeah.
You can see my left.
It's very obvious. Yeah. Like when I was in 7th grade, I have a distinct memory of this guy across from me at a table being like, what is wrong with your elbows? Like we have it broken. So when I say it's very pronounced sometimes, some of our joints are so obvious that people think like we're injured. Okay.
Yeah.
Still, we want you to be prepared for the exam and what to expect, because some joints are not as flexible as others. And you may want to point out, hey, I have these other issues, or I have an injury in this joint, etc. But we'll talk about that.
Yep. And so the Beighton score is tallied after measuring the knuckles of both little pinky fingers, the base of both thumbs, both elbows, both knees, and your spine. Toe.
Which there's only one of.
Only one spine. Thank God.
Yeah.
Causes enough problems.
Are we being really?
Seriously. Could you imagine
pretty intense spine
degenerative disc disease and you have 2 spines? Jeez. No, thank you.
As you listen to this episode or prepare for this medical evaluation, we recommend care with your joints. If you experience problems with hypermobility symptoms, and like the majority of us, you are now middle-aged, it's likely that they give you a little bit of trouble because, like we stated before, the average age of diagnosis is about 40 years old. So you're probably actually at that stage of progression now. You're past
above average.
We are both above average in so many ways. But so if any of these joints are problematic or injured, you may not be able to assess it. Also, other joint disorders that are related to like autoimmune conditions are more common in hypermobile EDS patients. So you may have joint inflammation. If you have a day that the pain is not severe, I actually recommend you take a video of yourself, have someone else record it or set it up, so it's stable. Recording those joint movements that they do in the measurement described in the Beighton score to take with you to your medical exam in the event that you can't tolerate that same movement that day. So, for example, another thing that happens with us is you may have really tight muscles. I have the back of my thighs are constantly so tight that unless I've done a lot of stretching, I cannot touch the floor with my hands flat any longer. Although I can, it greatly varies for me and my ability to do it.
The muscles preclude you, not the joint.
My muscle difficulties as a result of my hypermobility now at this advanced age. Also, I have hip dysplasia, so I have severe hip pain. So some days I can't do that just because the pain is so severe.
Right.
So my point is, sometimes we wait a really long time for those appointments. If you've got a day where you're like, oh, I think I can, do this today, go ahead and put that in part of your preparation of materials for that evaluation appointment where they actually measure. But so let's actually talk about how they do that.
Yes. But before, you brought up a good point talking about taking a video. And that's why I don't remember what episode, but we were doing I mentioned symptom tracking, taking videos, and that's good for tracking your symptoms too and showing your movements. And also, like, I struggle with using words sometimes to describe actions or what I'm doing. So having that visual presentation to show that this is what I'm talking about, because sometimes the words just don't flow. So but back to Beighton. So the movements that you're going to have to do in the interest of our own joint health, even though we do like our party tricks, we are not going to demonstrate. And as we're going to do our best to describe these verbally, as I just mentioned, sometimes we struggle with that, but that's why it's written down for us. Thank you, Luna. Because if I had to I was about to say free ball. Not free ball. What is the word? Not beep. What? See, we're talking about words not coming
now.
Not free balling. What am I talking about? Riffing, like off the cuff. Ad-libbing.
Because I'm so distracted by free balling.
Ad-libbing. I'm talking about ad-libbing, not free balling. Anyway, if I had to ad-lib the descriptions, it would be very bad. Anyway, if you're watching the video version of this, first of all, do you like my shirt? Second of all, sorry, we're gonna just go. All right, so we're gonna put the pictures up while we're describing so you can see it. If you feel good and I'm not even gonna say it. Luna, what's the first thing we're gonna do? We're gonna start with pinkies.
Okay, so speaking of the hand of the queen, we're gonna start with the hands.
You have to be watching the video to get that.
Yeah, you have to hop on YouTube. Otherwise you won't get this show. So the first point in the scoring is your fifth finger, aka the pinkies. So with your forearms and the palm of your hands flat on a surface, try bending backward the littlest finger. Okay. So we're going to put the picture up and show you what the position is of your forearm and your hand and your wrist. So can your pinky fingers extend backward beyond 90 degrees? 90 degrees is a right angle, okay? Like the corner of a square, okay?
Yep.
If your pinky finger can bend backward, I want you to add a point for each pinky, right and left side.
Okay, now Luna, what is your score on this one? Do you have 2 out of 2?
I can do both. Okay. And it generally doesn't hurt me. We will see. I am having wrist pain today, so I don't have a surface, but I can go quite far.
I'm 2 out of 2 too. I'm not going to do that. My hands are jacked up today. I'm not going to do that today. So we're both 2 out of 2 on that. Okay, so next is your thumbs. So with your arms outstretched and the palm of your hand facing downwards toward the floor, palm of your hand downward, can you pull your thumb backwards to touch the inside of your forearm? I cannot do that and never could. Those are the 2 points I don't have.
I don't know that I can show the camera, but I can.
Yeah, I can see it. My niece can do this.
So what's odd though is my hand anatomy is a little different. One side of my thumbs, I will show the screen. I can bend that joint completely backward.
Ow.
So on that joint, it's even weirder. But also my left hand, my wrist is really hurting today, so I'm not going to do that.
Okay. So if you can do that, if you can pull your thumb backwards to touch the underside of your forearm, you get 1 point for each thumb that can do that. So I'm 0 out of 2 on that. Luna, you're 2 out of 2?
2 out of 2.
Okay. All right. Next, Luna, elbows.
Okay.
I think we know what my score is on this one.
So your elbows are the joint in the middle of your arm, of course. This is your funny bone. It's your funny bone extra funny, basically, okay? So with your arms outstretched, okay? Normally, I think most people's arms are pretty straight.
Yeah.
From shoulder to hands, right? We want you to put your arms outstretched and this is so hard to do, your palms upright, facing the sky, okay, or the ceiling. Does your elbow bend backward? Okay, like I don't know that I can really get it on the screen, but mine are very backwardsy.
You can see mine here.
And I've actually been doing PT in my elbows, or OT, excuse me, because I have ulnar nerve compression through my elbows because it's been so severe. Now, the good thing is it's really only my left side that hurts terribly. As I should have shown you with my right side. But I've been doing work on it, so maybe it's a little stronger. So yes, so we both get double points for that. I know Shelley showed us earlier her cray elbows. So.
My cray elbows. All right. So now we're going to do knees.
So now you got to stand up. So we're not going to demonstrate this.
I'm not going to stand up. Stand up and lock your knees. And if you don't know what lock your knees is, it means extending the knees backwards as far as they will. So like, not where I actually generally stand without my knees locked, because if they're locked, it hurts, because
I have to think very hard about, hey, soft knees, soft knees.
Yep. Because when you lock your knees, if the angle of your knee extends greater than 10 degrees, like your elbows, that's kind of this, think about it that way when you're that's how I had to visualize it. Cause I didn't realize for a long time my knees did this too, just because of the way I viewed them. And then no, my knees do that too. So if your knees do that, 1 point for each knee. So I'm 2 out of 2 on that, Luna.
So funny story. I thought that mine were that they were not going to meet the criteria, but when it was measured, they did. And I've actually had some knee problems. Anyhow, even having had, seeing other people have more severe hypermobility, my daughter's knees go much further than mine. Even having some knowledge of that, I was like, oh, my knees aren't going to be. No, they were. They were like 15 degrees. So, but also, I am a chubby zebra, is my hashtag I created. I have pretty pronounced lipedema. So
that's common in EDS.
What that means is I have extra fat deposits in my lower body, particularly and in my appendages. So you can see it. I will show you. I have extra fat deposits in my upper arms, like, see I have skinny arms, skinny face, but I have some oddly proportional fat deposits in my rear end and my legs. We'll talk about that in another episode, but my point in saying this is that can kind of hide some of the angles, because the fat deposits are distributed differently than in typical anatomy. So I have fat deposits in a columnar shape around my leg. So it hides the angle. And also, like, I have fat deposits where you wouldn't, like I have fat deposits in my knee more than typical anatomy.
So is that why some people assume a person with a larger body can't be hypermobile, because they can't see it as, like, my elbows, it's really obvious, and you can see it more visually than someone who would be larger. So
my elbows are very obvious regardless of the
yours are, but I'm just saying, like,
but I will say in my legs, I don't see it as much because it does mask the angle, but also because the fat deposits are much more pronounced in the lower body in lipedema. That's kind of a classic presentation, but it is interesting that the fat deposits are the same throughout the whole, like, not the same, but it's the typical presentation is it's known as columnar, meaning there's a fat deposit around the whole, it's the whole entirety of the leg. So it doesn't look like what we expect normal anatomy to look like. So it does hide, it masks the shape of your muscle in your leg.
That makes sense. That tracks.
Also, what's interesting is because of my view of my body before I understood what lipedema was, I worked very hard to try to get rid of the fat and be healthy. And I did a lot of strength training, and I have amazing legs and glutes. I have a lot of strength. And that also, my giant quads also mask the hypermobility because it's so stabilizing, which is a good thing. But also, if I do just relax my muscles, look, there it goes.
Our bodies are so weird.
They
Okay,
are.
so
But also, lipedema is very comorbid in Ehlers-Danlos. There is medical research on it. So if you are a person that you think, well, I have a larger body, so this doesn't apply to me, and I've been told this only happens in skinny people, they're wrong. That is a misconception. It is inaccurate. I was technically obese at one point in my life. I was hypermobile then, just as I am now.
yep.
And in fact, I would say it contributed to my weight issues because one lipedema made me mess with my head and I just gave up on taking care of my body. But also the lack of ability to maintain physical exercise, the depression, the neurodivergencies. I could go on and on, but
All connected. Okay, so we did pinkies, thumbs, elbows, knees. We got one more place. What's that? That's the
okay,
spine.
your spine. So you're back.
Okay.
So the last portion measures the flexibility, not fully, but in one way, it measures the flexibility of your back and trunk. So we'll only have 1 point since this is not obviously a right and a left side thing. So still standing, you will bend forward, and without bending your knees, can
Your
you touch
hypermobile
the
knees.
floor? Here's the floor. Can you touch the floor with your hands flat on the floor? Okay.
I have a question.
Mhm.
And okay, I have not taken a single anatomy class ever. I'm just trying to think. If
And I have
you,
extensively, so
yes,
go ahead.
yeah, if you are bending forward with and you're hypermobile with your knees locked, so your knees are gonna hyperextend.
Mhm.
Doesn't that jack up measuring your spine?
Sort of, yes. And that's kind of the point. So if your knees hyperextend,
Well, I feel like you're an automatic on the floor.
likely, unless you have really long limbs, if your knees hyperextend, that means your knees are going backwards, which means your legs are curving. So then you are closer to the ground.
Right. So could you get a false positive on your spine because your knees are so hypermobile?
Possibly.
I don't know. I'm just thinking.
But so, I mean, really, this is measuring just one movement of the spine.
Well, right. That's why I'm
Also,
like, why are they basing so
there's
much
many
on this
other
one thing
indicators.
that could be skewed by your knees? Like that just
Yeah.
seems to me. But I
So
mean,
my
I know we're
mom
going to
can't
talk
do
about,
this, and I don't think she ever could.
but her knees
And
go.
no, her knees
Okay.
aren't. She's
I,
very
I
hypermobile in her neck, and
bobblehead.
actually has had 2 surgeries. But so my point is, her spine hypermobility is kind of you couldn't have
Different.
tested it this way. So what is also not tested in this and precludes me from doing this most of the time is my severe pelvic and hip hypermobility. I have what's called hip dysplasia, meaning my hips come out of the ball and socket joint.
That doesn't feel good.
I mean, that is one of the most severe presentations of hypermobility.
My
And
sister was
it
born with her
precludes
hip
me
out.
from doing this.
Yeah. My sister was born with her hip out of joint. Like they put it in and then she wore a brace for like the first 9 months of her life.
Yeah.
Damn. So you get 1 point if you can do that.
Mhm.
Okay. So now let's, if you're playing along at home, let's add up your points. Out of 9 possible points, what was your total, Luna?
If I would do this today, I could not do the spine.
Okay.
So I would get 8.
Okay. And my score is 7.
And when I was tested, I could do the spine.
Okay.
But it was very painful for me.
Yeah.
By the way, I did not learn that I had hip mobility until afterwards. If I had or hip dysplasia,
Yeah.
if I had known, I would not have done it then because I still would have obviously, had a high score.
Yeah.
I won't do this for fun at all anymore because it causes I have such instability in my pelvis and I'm constantly fighting my hips that I won't even try to do that. So the total score can indicate hypermobility depending on your life stages we discussed. So 2 key questions pertinent to now determining your score meaning are 1, have you experienced puberty? And 2, how old are you?
Okay.
So Shelley and I both fall into the second category. We've both experienced puberty, but we are both under 50.
Yep. Got a few
So
more years. The point thresholds for the Beighton scores indicating hypermobility are, all right, for people who have experienced puberty and are under the age of 50, like us, you have to have a score greater than 5, greater than or equal to 5. Mine is 7. Luna's is 9. I skipped over the children.
no,
Bear
mine's
with
8.
me.
If I were to test today, I'm 8.
That's
But
right, you're 8.
when I was diagnosed, I was 9. Yeah.
Okay. For prepubescent children, a score of greater than or equal to 6 is a positive score. And if you are older than 50, a score of greater than or equal to 4 is a positive Beighton score.
So my daughter's score was also 8.
Okay.
She can almost touch the 4, but not fully. And she was she's
on the
starting
cusp.
to, yeah. So they were like,
Yeah.
but still it was much greater than, it was greater than 6. She was an 8. But also, they may even say for a prepubescent child, we're not going to worry about it too much.
Right,
Literally,
because let's see what happens
let's see what
with
happens.
puberty.
Yeah, but they're going to follow that. Yeah.
The weight, I have issues with the wait and see. But anyway.
Yeah. So if your score is just 1 point off from the score given from your group,
Okay.
like the one below, then you would proceed to the clarifying questions in the next half of the HEADS Criterion 1 box.
Okay.
So this is known as the 5-part questionnaire for hypermobility.
Okay. So we're done with the physical scoring part. Now, on the HEADS diagnostic checklist, the next step, Criterion 1, has a bunch of questions, and they're going to ask, what are these questions about? This is why you need to know about your family history, or is this your history?
This is a particular questionnaire that came from a research study on hypermobility by Hakim and Graham. We mentioned this as a helpful screening tool in a previous episode. It is and has been identified as a reliable screening tool and predictor. In and of itself, it's a reliable screening tool, just to conversationally ask these questions. So it was added to the diagnostic criteria. It is also now used to expand on the limitations of the Beighton score. So let's review the questions for you. So Shelley,
Yes.
first question, I'm going to ask you them, okay? Can you now, or could you have ever placed your hands flat on the floor without bending your knees?
Yes.
Okay, so you see how it's addressing that limitation of the Beighton score. When I said I can't do that now, it's, yeah.
Okay.
Can you now, or could you ever bend your thumb to touch your forearm?
No.
Okay. And as a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits?
100%.
100%, yeah. As a child or teenager, did your kneecap or shoulder dislocate on more than one occasion?
Yep. I put it back in myself.
Yeah, my dad taught me how. Do you consider yourself, quote, double jointed?
Yes. And I hope we talked about how double jointed isn't a thing.
Yeah. So that's not a term, but it is colloquially
It's not a
commonly
term,
used
but it's a term.
If you've been called double jointed, you probably have hypermobility.
Yeah.
But so those questions are those questions that came out of that research from those hypermobility researchers that are all about your history prior to now. So you see how it kind of addresses the limitations of
things you can do.
progression.
So how many of those do I have to say yes to?
So answering yes to 2 or more of those questions, those 5,
Okay.
suggests hypermobility. So if you have a positive Beighton score, as we defined, that's subclinical, just one below that threshold. And then you also now have 2 or more of these questions that you answer positively, then you meet the criterion for box 1 on the HEADS checklist, and then your doctor would proceed to criterion 2.
Okay.
And which is a much more detailed assessment of your physical signs beyond just the joints, as well as your personal and family medical history. So we'll discuss that in the next episode in greater detail. But first, we're just going to stay on this topic with just the Criterion 1 and discuss the concerns from the community of patients, researchers, and practitioners that have been using this scoring system.
Yeah, so we hinted that there were some problems, and you heard me even ask some questions as we were going through this. What are some of the issues with relying so heavily on this, and why should we be concerned about the criticism of this current diagnostic tool?
It has been established that the Beighton score ability to truly reflect generalized joint hypermobility is questionable, and this is concerning.
All right, so in this segment, we're going to be summarizing the points made by Malik in a 2021 article. And the purpose of their paper was to review the validity and the reliability of the Beighton score as an assessment method to classify generalized joint hypermobility and to further discuss its suitability for diagnostic purposes. So unrecognized hypermobility disorders may lead to patients being denied access to appropriate healthcare. And I've actually already experienced some of this, and you probably have too. But in addition to that, it can also preclude you from getting the necessary disability support needs that will enable you to have employment or to increase your economic output and to lead a fulfilling social and family life, like live a life like the American dream or any dream of people who want to live a life.
Yeah. In general, what we're saying here is the Beighton score can kind of inadvertently be used as gatekeeping a disability diagnosis that could improve your quality of life. So the criticism of the Beighton score is related primarily to 1, its pertinence, 2, its narrow focus, 3, the quality of research evidence, and 4, bias.
Okay, I knew some of the things you mentioned, but pertinence, like relevant, like it's not even.
Yeah. Let me. So I'll expand on each of those.
Yeah. Because that. I mean, the other ones I get. Okay, cool. Yeah.
So the initial criticism of the Beighton score is related to its origins. Remember, I told you it was related to.
Okay.
How applicable in clinical practice are research tools when it's over a half a century old and hasn't been updated? It was just used for field research. So the Beighton score is a tool that is now 51 years old, and since its creation in 1973, it's remained unchanged and adopted as it stands for both research purposes and for clinical diagnosis. Okay. So the study that identified those particular points, those joints, had no particular evidence-based justification either. Remember, I said
as to why those points were chosen.
Yeah, so it wasn't about. Yeah, so it wasn't about like a diagnostic. It was more about the ease of identifying. So the joints were chosen mainly for the functional ease of access in the field. Remember, they were studying a culture that they didn't share the language or culture. It was very different from them.
Those are all movements you can easily mimic.
Scientists studying the Bushmen of the Kalahari.
Yeah.
Okay. So it was quick, easy to perform, and it was not limited by their differences in culture and language. So 2/3
non-invasive physically.
Exactly. Not invasive. They could do this in the field. They didn't have to convince them to come to an examination room. 2/3 of the joints assessed in the Beighton score are in the upper body, easily visibly seen in conversation.
Yep.
As an aside, criticism of the Beighton score should not discredit the great, amazing work of both Peter and Greta Beighton. So zebras would not be this far along without their incredible dedication. No.
So that actually makes more sense when you think about it. So tell me more about the narrow focus. You mentioned 2/3 of the upper bodies.
So the Beighton score only represents 9 points. So it's vital to know that if a doctor assesses your hypermobility in a rushed or cursory way, because let's be honest, they get 20 minutes to see you, a provider that's not really familiar with hypermobility disorders may inadvertently skip over some key aspects of your full health situation. So several other things should, of course, be considered. As you've been listening to us, you've probably already recognize this in yourself. Other symptoms, score adjustments may need to be made related to age, injuries, past surgeries, and then also, assessment of other joints beyond just those 9 in the assessment. So the 2017 criteria for heads standardized actually the Beighton score even more tightly to reduce false positives. So previously there was kind of some wiggle room on those thresholds total score numbers. The heads criteria in 2017 actually said it's this, or this. Here's the age limit, and that's it. So that was previously kind of more up to a practitioner.
I don't like that. It's already hard enough to get a diagnosis, and then you add in where the doctor has discretion to be like, meh.
So when I use the term gatekeeping, I don't think I'm exaggerating.
I agree.
So remember, this is a disorder of the connective tissues that presents as a spectrum and across multiple body systems. It varies between family members, right? Mm-hmm. So with the Beighton score, whatever you want to call it, with this tool having an all or none result, there's no consideration sometimes for
there's no nuance
no nuance. So the extent of multisystemic symptoms is not identified with the Beighton score. Some of the most devastating symptoms hypermobile humans face are not even addressed in that initial screening portion. The first step, we've already limited what we're examining. Okay. So additionally, as our hypermobile bodies age, the presentations progress from what they call a hypermobile phase. This is when we're really bendy without a lot of pain and without a lot of devastating consequences. Then we move into a pain phase. And that's probably when you started to seek help without answers. And then finally, what we call the stiffening phase. So
stiffening.
Yep, here we are.
By the way, familiar with that phase.
Before we even start recording, Shelly and I spend a while situating all the pillows and support and trying to get comfortable because it's difficult for us to sit still this long because of the pain. And
I need to tell you, I am so glad you're doing the majority of the talking today, because when you talk, I'm not on camera. And if I was, and people watching would just see me, I don't think I've been still this entire episode. And this goddamn earbud will not stay in my fucking ear.
So I just told her that my friend was like, my earbuds won't stand because our EDS skin won't even hold those in normally.
And these are the special earbuds that are supposed to stay in your ear. Like you're supposed to be able.
Okay, so a non-official screening tool we have decided for the EDS criteria is keep your earbuds in, because none of us can. Okay. Anyhow, okay, so jokes aside, yes, we stiffen as we age. And studies have shown that the Beighton score decreases with age, although pain probably and does worsen. Also, since so many of us are undiagnosed or not diagnosed into middle age, obviously the extent of our hypermobility is historical. It's our past abilities. It's not like we are compromised.
Yeah. No, I can't do a back handspring into the splits anymore.
No.
I even thinking about that makes me wanna.
Why did we do this?
Why did I do that? Well, I liked dancing. That's why I joined cheer. I joined cheer because I liked music and I wanted to dance, but then I had to be around all these bitches.
Yeah, I know.
So, okay. So now, what do you mean about when you said there was a question as to the quality of the research? Because quality definitely matters when it comes to research.
Okay. So quality with research is also based on, like, I hate to say this, but quantity, like repetition. So part of applying medical research is replicating outcomes. So the reliability of the Beighton score has been questioned with struggles to actually reproduce the research outcomes. So used from their originating epidemiological studies in this narrow South African population. So in 2006, okay, also let me back up here. There hasn't been a lot of research in hypermobility, period.
That's okay. I was going to say that, but also, like, as you said before, hypermobility is also very individualized. So of course they're not going to be able to replicate that shit.
Yes. And so anyway. This again, the Beighton score is from early 70s. In 2006, I'll let you do the math. That was a little
I'm not mapping today.
while into the future, right? So
Oh.
there was a study done, and it concluded that the score was insufficient for diagnosing joint hypermobility syndrome. And then in 2011, another study questioned the reliability and ability to reproduce outcomes. Okay, so that's 2 studies, even though there's very limited research on hypermobility. There's 2 studies saying we can't reproduce this. And then still, the most recent criteria for heads was published in 2017 using this Beighton score as the first step in the assessment. The initial first step of assessing for heads is using a score that is outdated and can't be reproduced. And almost as soon as the 2017 criteria for heads was released, it was scrutinized, and an international panel is currently reviewing the Beighton criteria. So it's under review. That's the good thing.
Okay, well, that's good. So it seems like they're reviewing it like they do the DSM, like it's
Yeah,
just
but it's a process.
It's a slow pain. Okay, so now we're on to, you mentioned, okay, so the bias, like the gatekeeping, or no, that's not the gatekeeping. That's just different bias. So, or is it both? Which bias did you?
Bias is not intentional gatekeeping. Okay, so bias is something generally that we're not aware of. So bias is any factor that can skew the results or conclusions of
like confirmation bias
research. Yeah, that's a type of bias. So bias itself has been studied in many contexts, and it is known to be present for many cultural reasons, of course. Good news, I'm not going to break down any of the medical research on bias. There is some if you're interested, because that would be going down a very deep rabbit hole. But the quality and bias of the studies that have contributed to the current diagnostic methods are being examined. So the research conducted so far shows that we do not know enough about things like racial differences, but however, has shown some consistency in patterns in both age progression and more pronounced symptoms in those of us assigned female at birth. So not even going to go down that rabbit hole, but there is bias towards older people, and there is bias towards those of us that menstruate. From the 2021 article by Malik et al., which is the review of the Beighton score, quote, with regards to racial differences, several studies have shown a general trend of Caucasian, and by Caucasian, they mean white European descent, not people from the Western Caucasus, demonstrating a lower prevalence of generalized joint hypermobility, which is increased in Asian, African, and Arab populations. However, it is not yet established if this is associated with a higher prevalence of hypermobility-related symptoms, with studies demonstrating conflicting results. Okay, so I'm just going to pause right here and say what is interesting in the diagnostic journey for both me and my child is that we are very white presenting. However, our dominant background is not white European, despite our visible presentation.
So your phenotype doesn't necessarily look like your genotype.
Exactly. So how you look,
biology.
How you look may present some bias in your treatment as well. We're not even go there right now. But so combine the bias with the research, combined with the bias in your own healthcare, and here we go down a rabbit hole.
And then the meta. Yeah. Oh my gosh.
Okay. So continuing with Malik's article, the prevalence of hypermobility has consistently been shown, though, to be higher in females across the lifespan. That's very important. These differences become more pronounced consistently, by the way, in research around the age of 14, with females demonstrating significantly higher rates of hypermobility, while the decrease in hypermobility following adolescence is more pronounced in males. So the prevalence rates of hypermobility within specific age groups are difficult to accurately discern due to sample ages and sex varying considerably within studies. So if we repeated studies with consistent samples, then maybe we'd be able to better compare. However, hypermobility has definitely consistently shown to be highly prevalent in the youngest children and has been shown to decrease with age, falling rapidly throughout childhood, and then at a slower rate during adulthood. So the collective findings of this article reviewed multiple research studies, demonstrated a need for a change in critical thinking. The Beighton score should not be used as the principal tool to differentiate between localized and generalized hypermobility, nor used alone to exclude the presence of hypermobility.
Okay.
Greater emphasis should be placed on a clinician's judgment to identify and exclude hypermobility according to its full definition. So it's pretty clear that further research is needed to better understand joint hypermobility and how it presents in the various forms of EDS and the other related irritable connective tissue disorders, and to find the most effective method with which to clinically identify these presentations. Okay, this article, God bless them, God bless her, does not mince words. Okay, it raises ethical concerns when it appears a diagnosis is restricted to meet a specific prevalence rate rather than reflecting the actual physiological presentation of a condition. Now, when I tell you that this is an underdiagnosed disorder, and the prevalence is not actually understood, I'm going to tell you that there is some unpublished research. The general terms that are being thrown around by the folks at USC looking for the HEDS gene,
right? Yeah.
They have a pool of genetics that can't even keep up with now. They are suggesting most of their genomes are coming from North America, that the prevalence rate is actually 1 in 500. So what we're talking about is a health crisis, generally women. Okay. But also, so we're just gatekeeping disabled women here, generally women. There are men with this.
Generally women, and also women who are Black and brown, and like we always do.
Different cultures. And do you remember what I said? It is presenting higher in people of color.
Yeah.
Okay.
So okay. I've read a bunch. I haven't read as many articles and reviews of things as you have. And clearly we agree. Like, she did not mince words. So my question is, like, I haven't really read an article that from a medical person who is also so critical of their own field. And so, like, I feel like I could have, like, why do I relate so much to that?
That's because Dr. Malik is an EDS patient herself.
Oh,
there is actually a lot of great research happening, and I'm going to let you in on a secret. Often it's a fellow zebra behind the scenes. Okay, so a great hack for hypermobility
is to go into the field of hypermobility or connective tissue and research and just figure out the problem yourself.
Yeah. But for those of us that didn't make those life choices, one of the things that I enjoy, and that's why we're here, is that I like finding these other hypermobile humans that are actually in the STEM field and researching our conditions, because they relate to us, they're real, and they're doing amazing work. And some of the most helpful ways I've stayed up to date on their research and the hypermobility news is by following the social media and research being done by fellow zebras. In a previous episode, we mentioned Dr. Courtney Gensimer, who is working on that project I mentioned to find the HEDS gene at the University of South Carolina. I've listened to interviews with her and Dr. Norris, in charge of Norris Lab there where they're studying it, who said, like, she came in and basically said, like, we really need to do this. And he listened to her, you know what I mean? And they have internships for zebras at Norris Lab at USC. That's cool. A lot of us that are younger zebras are interested in this and are making it, their life's work now to study genetics or go into medicine or nursing or something. I have a relative in nursing school right now who's greatly affected by both HEDS and endometriosis. And that's why she's in it, because she suffered so long without acknowledgement, diagnosis, and proper care. And there is research, by the way, happening quite amazingly at great lengths and maybe even at greater volumes outside of the US as well. I don't want to limit it just to the United States and the UK. There's research happening in Israel, Japan, Rome. There's amazing researchers that are very dedicated to this subject throughout the globe. We referenced an important article from last year throughout this episode by Dr. Malik. I wanted to take the time to give a little background on the lead author. is both an EDS patient and UK PhD researcher in the field. Interestingly, part of one of my diagnoses does appear to occur more commonly in South Indian and Middle Eastern descent people, and that's why it was not initially considered for me.
Interesting.
And by the way, I am that. So not only was she part of the Beighton score review project, but she was also the primary author of this 2021 article that proposed an updated definition of EDS-HSD and to identify potential biomarker for the EDS-HSD subtype. So if you remember that biomarker news in 2021, that was her, Dr. Malik. So their updated definition is the hypothesis that, quote, EDS-HSD could be a disorder of membrane-bound collagen, which occurs when fibroblasts can no longer attach to collagen. And that article is called The Role of Cell Adhesion and Cytoskeleton Dynamics in the Pathogenesis of the EDS syndromes and hypermobility spectrum disorders from Frontiers in Developmental Biology. So when I tell you, these are very nerdy, amazing zebras doing amazing work. Yeah, so she's part of also something called Heads Together, Tee-hee.
I like it.
Neurodivergent joke. So Heads
I'm got my phone out now. I'm getting on Twitter to find her.
Which is a great website to use as another resource that is also UK based. This is where she's based out of. You can find her on Twitter as well, and we'll link that also.
She needs more followers. She only has 3,200 followers.
But that's how I learned about the biomarker discovery. Was from her and from her Twitter.
Okay. Well, now she has one more follower. I just followed her.
So some other zebras that we haven't mentioned on the show yet that are also great resources are Dr. Sharon Muglatheory, MD, who has a very interesting website dedicated to her theory. So she is also a super science nerd, obviously. She is both a board-certified psychiatrist and internal medicine physician. And she originated what is known as what she calls the RCCX theory, which she theorizes may explain overlapping syndromes associated with chronic illness, including hypermobile EDS, chronic fatigue syndrome, fibromyalgia, Lyme disease, MCAS, POTS, pain, psychiatric spectrums, immunological, and endocrine issues, as well as the neuropsychiatric markers that predict the risk associated with these disorders.
Ooh. Check her out.
We'll link her website as well.
Yep.
And then one I haven't mentioned yet before either is Dr. Emily Casanova, who is a PhD and has an interesting blog and Twitter, which we'll link. And she is an assistant professor of psychology at Loyola University, but she did also work at Norris Lab at USC.
Okay.
She is a neuroscientist.
Nice.
And neurodivergent human. And biological scientist with a primary focus on my favorite intersection, the inherited connective tissue disorders and autism. Awesome. And she has both a blog and a Twitter. Sweet. So I will warn you that these tweets are spicy, y'all.
Oh, yeah.
No, these
like people... Shelly spicy? Like Shelly spicy?
Yeah.
Okay.
So Dr. Reinhold kills me. I mean, like, I like these people. I've never met them. I've talked to Courtney Gensimer, but I haven't talked to anybody else. I would love to. I would love to get all these people in a room, and I'm sure I know they've been in a room. Some of them have met each other, and they have, Anyhow, there are zebras in STEM, and they're making a difference.
Good.
And so my life hack today for hypermobility hacking is find those zebras in the field and follow them on social media and stalk them for all the updates.
Yeah. For the updates only. Don't actually stalk them.
Don't actually stalk them. Courtney's on TikTok with us.
Oh, is she?
Yeah.
Does she follow me?
She did officially receive her PhD. She's no longer a candidate. Yeah.
Well, congratulations, Courtney. Yeah. Dr. Courtney. Does she follow me or just you? You have so many more followers than me.
I don't know. I
think it's because I'm older and I don't know what the deal is. I don't really care anymore.
I have made a lot of videos about medical research.
You do more of that. I'm more random. I like to be random.
That's okay.
I'm fine with it. I just am sometimes sometimes I'll post something really good and I'm like, this is good.
And why did I all the time?
And then 4 people like
things
it.
that I think are important never take off.
Yeah.
It's
Although
the stupid little things.
I do have one that's getting a lot of visibility now, and it's good because it's a duet with an intersex human, and I'm talking about social constructs of gender. And what's surprising is I just duetted that and like added some commentary, like from my undergraduates in anthropology, and I am surprised. I mean, the original video did gangbusters, the human's original video, but then my video has over 200,000 views and like thousands of shares and stuff, and I'm like, this is just me duetting it, but that's good because
Also,
the visibility.
You should know that there's a higher instance of not just overlaps that I mentioned with the connective tissue disorders and neurodivergencies such as autism, but also with those of us that have gender differences or that are in the queer community, period.
Yeah, so, there's the overlap with the rainbow mafia.
I actually made a joke video that went viral saying, hey, did y'all hear about the new criteria for heads? And people took me literally.
Oh, they really did. I remember that. That was.
And what was funny, the person like who stitched it is studying in graduate school for genetics.
Yeah.
Also, I'm super proud of her. She's in Maryland.
She's from Maryland?
Yes, she's near you.
Oh.
Yeah. So, but she's also someone else in STEM. She hasn't graduated yet or anything. But my point is, like, she makes jokes all the time, and we've laughed so hard about like how we make jokes but we don't get other people's jokes.
Yeah.
And she meets the criteria of all three of those things, as do I. And she really thought that I had found, like, I had the inside scoop and knew.
She's like, hell yeah, what's this criteria?
Yeah, she really thought that I knew the new criteria for heads. And I was like, oh, no, y'all, it's a joke. It was a joke. You missed the rainbow.
Well, okay. So we're on this topic. How long are we stuck with this old criteria? Like, when do we have any idea of when they're going to have some updates? Inside information?
I don't have a ton of inside information. I do know that this research and these groups of people are talking, and I do follow. But so there are some different approaches to identifying hypermobility that were not used in the 2017 criteria. So I'm not going to break them all down, but so for example, there is an alternative 10-point scale. So it looks at more parts and has a wider
like
view of
knees and shoulders.
And so this is from the Hospital Del Mar in Barcelona, Spain. Like I said, it's not just the US and the UK that's doing this research. So they include the shoulder, the hip, the patella, which is
good, more points for me.
Your ankle, your foot, and your toes. And so honestly, if I can tell you, if Shelly were to go through this and I were to go through this, we would.
You should see my toes. They're actually contained in socks today, but they're novel socks. I can wear socks if they have novel. I'll show them to you later when we're done with this.
We only wear socks if they're okay, anyhow. But it does seem that a new approach is forthcoming. But like everything, in medicine, it takes further study and let's make sure this is reproducible and validate
peer review
that sort of thing.
Yeah.
Right. And also, this is still considered a rare disorder, even though I said it's just not as rare as we are led to believe it is. It's still considered rare, so it doesn't have the best visibility. It did so the EDS Society did get some amazing funding more recently and does have an increase in research happening. But I'm just going to leave this here. I want to read out the conclusion of Dr. Mallett's 2021 critical article on the Beighton score.
Okay.
So, alternative assessment methods and tools exist. However, with over 300 joints in the body, it is very unlikely any single assessment method will ever truly capture all variable presentations of generalized joint hypermobility. Okay. Pause, this is me talking. For example, did you know that it's likely that you experience hypermobility in your ears? This is something I didn't even consider, and I have such severe tinnitus and hearing difficulty and sensorineural hearing loss, and we have jaw issues, and they're all seem to be interrelated. And this is some of the biggest annoyances that me and my child face, and it causes migraines, and it's hypermobile ears. So even the tiniest bones in your body are affected by this.
So is that why when I was a child, I had so many goddamn ear infections?
Quite possibly. but also we tend to have issues with immune
Sinuses and
response. So
okay.
it's a
All right.
complex answer. I don't
Okay.
know. So anyhow, okay, moving on. So consequently, this has highlighted the desperate need for a clinically significant diagnostic marker or markers for the hypermobility disorders that would render such assessment methods redundant. Until such a time comes, use of the Beighton score as a diagnostic tool should be used as one with caution. It's useful, but not the end all be all, and it should not be the gatekeeper. Okay. So, indeed, this review has demonstrated that changing clinical thinking is required. In particular, the current use of a negative Beighton score to exclude the presence of generalized joint hypermobility is a practice that must be discontinued. This is not diagnostically inaccurate, but could deny a patient their fundamental right to diagnosis or even identification. So, when I tell you my mother I don't even think she would get a 1. And she has some of the most devastating EDS diagnoses available. Okay. So hence, we're potentially denying a patient their fundamental right to a correct diagnosis and hence access to appropriate support. This is an ethical concern. Instead, the Beighton score should be used as intended. In other words, as an initial screening method, after which other notable joints, for example, the shoulder, hips, ankles, and remaining digits, could be examined until the clinician is satisfied with no evidence of systemic joint hypermobility, and then, do that conclusively, nor any associated syndromic feature before excluding the heritable connective tissue disorders as a diagnosis. So that's my point. The other heritable connective tissue disorders don't all present with these either. So
right.
You're potentially, and the ones we do know the genes for can be very devastating and frequently do not pass this scoring tool. Okay, so greater emphasis should now be placed on a clinician's judgment and experience, obviously, to identify or exclude generalized joint hypermobility according to its actual definition. The presence of joint hypermobility at both the major and minor joints of the forelimbs and axial or core part of the skeleton throughout. The whole body should be.
Yeah. Well, I mean, so it's obvious that more research is needed, but are we missing the bigger picture by just focusing solely on hypermobility? So whatever the best outcomes are from when you identify it early, right? I think back, how much better off could I have been if they had known?
Yeah.
Right. So this is so exciting because this current research, if they find the gene, I can't move forward because of my mic. I keep forgetting. Yeah. So you mentioned the funding. They're doing that gap research is what it's called, right? Mm-hmm. It's been funded further, right? Yeah. If I'm reading this correctly. So now their goal is to fully understand it, find the underlying causes, and develop better diagnostic tests besides these, because there really isn't one.
So what we're finding and what we've been discussing is that this is really a spectrum of disorders. It presents very widely, although there's a lot of commonality. And once we find each other, we are usually stunned at our common experience. However, we have not found a way to clinically diagnose and assess it. Regardless, it's really encouraging how much opportunity in research there is and forward movement in the study of hypermobile humans. The goal for us as bendy people should be to have the opportunity to just improve the quality of our life and legacy that we leave to our children that inherit our disorders. But in the meantime, these are the current guidelines used by doctors to evaluate your hypermobility symptoms on the diagnostic journey. So it's important to know the details as a zebra, not only to know what to expect and prepare yourself, but to know when and how to advocate for a more in-depth critical assessment of your health and to say, oh, no, wait, what about this?
Yeah.
Shelley's putting things together, I think, right now.
Yeah.
Tell me.
I'm so grateful that I found this community and you and all these people, but it makes me mad too, all over again.
I know.
I'm getting better at the like rage, just because I finally feel like I'm getting onto that path of like.
I said that in a room full of zebras, the elephant in the room is the trauma. Us having to deal with the medical gaslighting, the systemic effects of this, and the long-term effects, not just in our lives, but how it affects generations, our family lives. We're constantly having to do the work of facing, and it's frustrating to think, well, what if I had had some help with this back when I was a teenager?
Right.
So that's why we're doing what we're doing. And that's why we want to empower you to have the knowledge that maybe we didn't have on this journey, and to know how and when to advocate for yourself, what to expect, what the pitfalls are, the current state of medicine. When you go see a doctor, they don't know all these things. Even probably some in the field that you may be referred to just aren't that up to date or interested in the connective tissue disorders.
Yeah.
The doctors like rheumatologists, geneticists, they don't all work in this narrow field. So they may not be aware of these concerns that we've just expressed to you. So you are going to have to be aware of saying, well, wait a minute, what about all these rolled ankles?
Right.
Things like that. So stay tuned, and next time we'll delve deeper into the rest of the criteria for hypermobile EDS. We'll go down the page with you.
Yeah. So thanks for listening. And I don't know. This is weird. You switched it up on me. I'm used to saying I know.
Me
And
too.
I asked you to switch it up on me, and now I can't do it. I'm a mess. So
I
go
did
ahead and
what
say
Shelley
it.
asked.
Yes, I asked to not always be plugging our show, and you did it. And then now I read my part and I'm like, oh, I can't read it.
Okay,
Anyway,
so
listen to us and share it. Go ahead.
Yeah, thank you for listening to the Hacking Hypermobility podcast. We appreciate you being here, taking the time to hang out with us and try to follow along. We would really appreciate it if you would take the extra step to take a minute to share or follow or leave us a review. I mean, really, please, on whatever platform you're listening to, leave us a review, a star, a rating, whatever it is, wherever you are. It helps us to grow the podcast, get visibility. And I don't care about that for us, Shelley. It makes us feel icky. But what we really care about and what we're passionate about is spreading awareness, because of what we just talked about, how important it is to us to change the state of our quality of life and diagnosis, and awareness helps, and nobody else is speaking for us. And as I think I just demonstrated, we're doing the research too. By we, I don't mean me and Shelley, I mean other zebras. The science is being done by the people in this. So, I mean, come help these zebras that are doing the research. Scream it louder for them. Anyhow, thank you. Try to give us a share. Give us a little plug.
If you're on any socials and you find, just share the link. Say, hey, listen to this. I know some of our episodes are longer. We try to break it up into parts to keep it manageable, and I try to label them in a way that makes sense so you guys can find it. And this one's going to be shorter,
and we put our little resources on the blog on our website too, and it has a link to our own TikTok pages if you like short, digestible, slightly funny videos. We do a lot of content on both neurodivergence and being hypermobile in the intersections, as well as some of our special interests.
I have like a lot of gardening stuff and some cannabis stuff, and I have a lot of cat stuff. My cats have a page. The other thing is I love nerdy t-shirts. And so if you have an idea or if you want to see me wear something,
send us a submission.
Send us. Or, I mean, maybe I should get us a PO box and people can like send us funny stuff. My shirt today says Vote Tyrion 2012. Lannister. A Lannister always pays his national debts. And
I didn't even read the subtitle. That makes it even funnier.
So this shirt, a lot of my fun shirts were gifts from my cousin, who is like my sister. She's not even a year younger than me, but she sends me all the best shirts for my birthday, and then I send her. Actually, the shirt I was wearing, the Doctor Who shirt with Maleficent, that was a gift from her. Anyway,
I love that we're both Maleficent people. I think that's awesome. Are you a Maleficent person, listener?
Are you? Do you like Maleficent? I love Maleficent. I need to get my Maleficent tattoo. I haven't done that yet. But what I was going to say, the reason why I decided to wear the vote is because I don't know when our next episode is going to be recorded. And the midterm elections are coming up. And voting is very important. And I'm not going to tell you how to vote because that's not what I do. But I just want you to think about the most marginalized person you know. Think about that person and vote with that person in mind.
I will second that. I would say if you're going to take some time to educate yourself on the local politics options in your area too.
Yeah, it starts with the school boards.
Yep.
Seriously.
Amen. Well, anyhow, I love you, Shelley. Thank you for being my zebra cousin.
I love you. Thank you for being my Shelley.
Oh. Well, wishing you all a happy and healthy hypermobility day. Yeah. Have a happy day, zebras.
Happy day, zebras. Bye.
Bye.
Bye. Oh, pretty kitty. Meow, meow.